dissect relationships. That's the trouble with dissections of fascia, because fascia is about relationship. It connects, it's a continuity. So if you want to make it visible, you have to disconnect the continuity. And that is, difficult for an anatomist. You see here the fascia, and here I showed you what the fascia is in the distal area. You simply can carefully take it away, and it's a thick layer, and under it is a spooky, spongy connective tissue of Guben. I don't know if you know Guben with the moustache, and that's the connective tissue of Guben, fitting spaces and enabling here the muscles to slip under the fascia. But here you see, you cannot remove that fascia so easily. You see that there's a complex muscle here. It's the ulnaris extensor muscle, is inserting with its fibers on that fascia. So the fascia is used by the muscle fibers so that a pinnate muscle is constructed. If you look in every anatomy book, even in the modern anatomy book there, you see that they don't depict it as a pinnate muscle. They think that the fibers, are parallel and go to the epicondyle. Because Vesalius said that, and Sobota said that, and Prometheus said that, so we all think that they go to the epicondyle, which is impossible. There are more than 1,000 muscle fibers in these muscles, so how can they go to the epicondyle? And that's not how it works. It works that via the fascia and via septal layers in between the muscles, to which the muscles are inserting, and then these layers converge to the epicondyle. That's how it works. So that's why I see here a pinnate muscle, and I cannot simply, I have to distort. Here again, you see the similar situation as it is here. Here's the anconeus muscle. That's only a muscle to registrate, the movement of the joint. Has not much forces to do, so it's not inserting to the fascia. The fascia is simply laying over it, covering it, and again there's the Guben tissue to enable motion. But now I made, to show the similar situation, I opened here the let's say the sheet, no, not the coffin or the case of an underlying muscle, and that is the extensor digitorum muscle. And you see that's why my heart is so bleeding. I try to leave some of the muscle fibers that are inserting to that fascia, to leave it there, so that I can show that when I take out the muscle out of its coffin, that its coffin is built by fascia layer, but also intermuscular septa, and then another and a deeper layer of connective tissue. So all these walls of that container go to the epicondyle. And the same story, it's a pinnate muscle. Look in the atlas. Until now, for centuries, they depict it as a parallel. That has to do with the medical artist. Because the medical artists do what the anatomists say. Okay, but you are an exception. You only draw.
I know.
You only draw what you've seen yourself. So the next step will be that I will remove more of that muscular tissue, and then we can see that whole layer system converging to the epicondyle. And I can already see, maybe you can see it in the depth. There's the supinator muscle, and the supinator muscle also has a fascial layer. And guess what? This now is the aponeurosis of the supinator muscle. But if I dissect away the supinator muscle, it will look like as if there is a band of connective tissue remaining here. Even in the holy hall of anatomy, there's a specimen of the elbow joint showing you an annular ligament. And even in that specimen, you can see that the fibers do not run like an annulus. They are like that. And you can see how sharp that annular ligament has to be detached from the muscle. It's an artifact. So tomorrow I will show you that it's possible to show you that this aponeurotic layer of this fascia of the supinator muscle is part of the delicate system of layers converging to. So that all is connective tissue, and there is not any muscle fiber inserted to the epicondyle at all.
You have the pros of fainting RK.
Huh?
The supination.
Amen.